Hello everyone, welcome to my channel. In this video, I'll be talking about ischemic colitis or large bowel ischemia. All right, so let's start with a question. This question is from USMLE. So, a 67-year-old man presents to the emergency department with abdominal pain. He states that his pain has been gradually worsening and used to be exacerbated by meals, but now occurs at rest. He also endorses diarrhea and notes blood in his bowel movement at times. His past medical history is obesity, diabetes, hypertension, and is generally not compliant with his medication. He also recently treated for sinusitis and amoxicillin. Blood temperature is 37, blood pressure is 157 over 98, pulse is 120, respiration is 17, and oxygen saturation is 98% on room air. Physical exam is notable for generalized abdominal tenderness, discomfort to palpation. Labs are as follows: high leukocyte count, sodium chloride bicarb is low, is 20, BUN blood urine nitrogen is 20. Okay, and a CT scan of the abdomen is done, and it shows this. Okay, which of the following is the most likely diagnosis? So the answer here is ischemic colitis. Okay, so uh, the following are the clues for ischemic colitis: abdominal pain, gradual worsening, exacerbated by the meals, and diarrhea, and noted blood in his bowel at times. Not always, but at times. Okay, and leukocyte count with these lab findings. So whenever you get a lab in your question, serum electrolytes like this in your question, it's given for a reason. All right, and you need to find out the anion gap in such a question. Okay, so the reason why they have given this is that they want to tell you, is this patient having any ischemia? So, it's important to find out if the patient has lactic acidosis, okay, by measuring the anion gap. So, if the anion gap is high, that means is um, metabolic acidosis due to lactic acidosis, okay. So, this CT scan of the abdomen demonstrate bowel wall thickening that is represented by the red arrows, which can be seen in ischemic colitis. So this patient is presenting with risk factors such as diabetes, with abdominal pain, bloody diarrhea, and lactic acidosis, and a CT scan demonstrating bowel wall thickening, suggesting the diagnosis of ischemic colitis. Okay, so you calculate the anion gap, which is sodium minus bicarb plus chloride. Okay, in this it's high, so this means that it's a metabolic acidosis due to lactic acidosis. Okay, so colonic ischemia is due to non-occlusive ischemia. Okay, that causes ischemia, especially in the watershed regions. We will talk about this in detail. Other causes may be atherosclerotic diseases, state of low blood flow like hypovolemia. Okay, so clinical features: moderate abdominal pain and tenderness, hematochezia and diarrhea, leukocytosis, lactic acidosis. So this patient had hematochezia, abdominal pain, leukocytosis, and lactic acidosis as well. So you do a CT scan. CT scan will show you colonic wall thickening with fat striating. Endoscopic evaluation shows edematous and friable mucosa. Management would be IV fluids and bowel rest, antibiotics with enteric coverage, and colonic resection if necrosis develops. It's very important to start off with antibiotics covering the enteric coverage, because there is a possible risk of rupture, and that the bugs can leak into the bloodstream and cause sepsis. All right, so you need to start off with antibiotics against the enteric bacteria. Okay, so this is essentially colonic ischemia. Now, a major distinction between colonic ischemia and mesenteric ischemia, or ischemia of the small bowel, is that there is no hematochezia in case of small bowel obstruction. I mean, small bowel ischemia. There is no hematochezia in mesenteric ischemia. So that's the major distinction between colonic versus mesenteric ischemia. All right. So and in addition, if you do a chest X-ray, abdominal X-ray, it will show colonic distension or pneumatosis or gas in the bowel wall. All right, this is another finding in bowel obstruction, and a lower endoscopy can confirm the diagnosis. All right, so that was colonic ischemia. Now let's talk about some of the other presentation in colonic ischemia. It's basically due to inadequate blood supply to the large intestine, leading to inflammation and injury of the colon. It's very commonly seen in elderly population, and the risk factors associated with this would be aortoiliac surgery, instrumentation, especially after abdominal aortic aneurysm repair. Very important one. This is commonly tested as well. Patients after repair of abdominal aneurysm may present with ischemic colitis. MI, hemodialysis, hypercoagulable states are other important risk factors. Pathogenesis is due to ischemia to the watershed areas. Now, what are these watershed areas? There are two main ones. One is splenic flexure, another one is the rectosigmoid junction. So the blood supply at the splenic flexure is from the artery, Desmond artery. Okay, and that's essentially very weak towards the flexure. The blood supply is weak towards the splenic flexure, and that can result in ischemia. Okay, so this territory of the superior and inferior mesenteric artery. So this part of the colon, the transverse colon, is supplied by the superior mesenteric artery, and the descending is supplied by the inferior mesenteric artery. Okay, so that's the communicating arteries. And the other one is this rectosigmoid junction, where the watershed area is between the sigmoid artery and the superior rectal artery. This is very high yield anatomical question on the USMLE. So the watershed areas are the splenic and the rectosigmoid, and you should know the blood supply. Okay. So the non-occlusive colonic ischemia may be is mostly majority of the cases presents in hypoperfusion, examples in shock or systemic hypotension. Occlusive colonic ischemia um, can be embolic. You know, patients after a atrial fibrillation can present with an embolus that may lodge into these arteries, especially the superior mesenteric artery. Okay, and so you always need to look into the risk factors as mentioned in the question. Risk factors for this pathophysiology include vascular risk factors such as diabetes, uncontrolled, hypertension, smoking, and peripheral vascular disease. Other causes may be mesenteric vein thrombosis. Okay, so the symptoms, as we have seen in the question, is mild, crampy abdominal pain, commonly involving the left side, hematochezia, and the ischemic colitis versus the mesenteric ischemia. The differentiating factors include presents with severe abdominal pain and does not accompany hematochezia. Okay, so there is no hematochezia in mesenteric ischemia, but there is hematochezia in case of large bowel infarction. Diagnostic approach, definitely in the clinical presentation, history, all right, and you confirm via endoscopy, right? This is very high yield. How do you confirm it? Via endoscopy, okay? So you do a CT scan, which is the best initial test, which will show bowel wall thickening in a segmental pattern, thumb printing pattern, all right? These are buzzwords for the examination, all right? Bowel dilation, mesenteric stranding, or intestinal pneumatosis. Exactly this way, all right? This is how thick bowel wall thickening presents. Okay, then what would be the next step? All right, the uh, sensitive test, or how do you confirm it, is with the help of endoscopy, which will show edematous, friable mucosa, erythema, and interspread pale areas. But you don't need to do an endoscopy in a clinical practice when your CT scan gives you the diagnosis. Okay, so the best initial test, however, would be a CT scan angiography, right? Angiography without oral contrast. Great. Next up is the management. Management for mild colonic ischemia would be supportive care, wherein you put the patient on bowel rest and observe. All right, you put an NG tube if ileus is present. Monitor patients with persistent leukocytosis, fever, or peritonitis. If patient deteriorates, then you may accelerate your treatment. Moderate to colonic ischemia, here you always need to add antibiotics. Antithrombotics are added in case of mesenteric venous thrombosis. This is one of our presentation as well. Extremely rare and usually involves the small intestine. If that is so, then you may add an antithrombotic therapy. And then severe colonic ischemia, signs of peritonitis, pneumatosis on imaging, or gangrene colonoscopy. All right. This is when you do an endoscopy. This is why you do an endoscopy, to find out if there is a gangrene. All right. So in that case, patients who are hemodynamically unstable, pneumatosis on imaging, then that would be, classified as a severe colonic ischemia, and that would definitely require exploratory laparotomy. All right, and in that case, it is indicated to resect the necrotic bowel if applicable. Okay, so that is all about the the um, ischemic colitis, right? In the next video, I'll talk about mesenteric ischemia. Thank you so much for watching.